Endocrinologist in Austin, Texas, and I'm at a practice called Texas Diabetes and Endocrinology. I'll say here in Austin. We have 3 offices, if you know Austin, and North, Middle, South, Round Rock, and South Austin. And I'm a boarded endocrinologist. That's what I do: cardiometabolic, diabetes, all those things, pretty much all day long. And what I'm going to do today is I'm going to talk about and review some things we talked about before. I'm going to talk about tirzepatide. Now, what in the heck is tirzepatide? Well, tirzepatide is Mounjaro, and that is that new medicine that got approved really very recently. It's an Eli Lilly medicine. So Mounjaro is spelled Mounjaro, but it's pronounced Mounjaro. And so that's the drug name is tirzepatide, and that's not going to be easy to spell at all. Tirzepatide, and it's the first in a new class of medicines. It is a new class, and I'll explain that a little bit. So I'm going to break this talk into a few different parts. We're going to talk about tirzepatide, and we're going to talk about how it works. We're going to talk about the diabetes data, and then I'm going to talk about some really interesting obesity information that's come through. So first in class of new diabetes medicines, but what about that weight loss? Whoa, we're going to talk about that. And first of all, I want to talk about how tirzepatide or Mounjaro works. Now, first of all, it's a single molecule. That's one thing that's really important. It's not some double hook molecule. It's not something that kind of two things stuck together. It's based on GIP. And I'm going to use some terms, I apologize, but I'm going to define them. And GIP is glucose dependent insulinotropic polypeptide. And so now you understand why you want to say GIP and not that. I mean, who would want to say that? And GLP-1 is glucagon-like peptide 1, and we've been using meds, they're GLP-1 meds for a while, like Ozempic, Trulicity. They're weeklies, and they're working for us very well, and we use them a lot for diabetes. And then that Ozempic is approved, it's semaglutide, and it's approved as that drug called Wegovy that's used for overweight, for obesity management. So, new world here, and this adds yet another twist to the new world. So it is a new drug class because it has GIP and GLP-1 like effect in one molecule, and it's actually novel, and it's a peptide, and it's engineered. And it has, if you're interested in, if you like to talk about amino acids, this one has 39 amino acids, and has what's called a fatty diacid moiety. Don't remember that. And it has a half-life of about 5 days, and so it can be given once a week. That's pretty nice. And it's an injection. It's liquid. It doesn't have to be reconstituted, and it doesn't have to be adjusted to renal or hepatic impairment. It's not metabolized there. It's kind of nice too. You don't have to worry about that when you're using it. So that's kind of a little bit about what I want to tell you about it. It agonizes, it does agonize the GLP-1 receptors in the body, and it agonizes the GIP receptors. And you may say, again, GIP, glucose-dependent insulinotropic polypeptide. It twists my tongue too. Well, what is this about? Well, GIP receptors are on the beta cells, and they actually agonize insulin production. So let me talk about what these two different receptors do. This is one molecule. That's why I said that, 2 molecules, see if you're awake and see if you're paying attention there. It's one molecule. Well, what GLP-1 does, and we've known this for a while, it reduces appetite, increases satiety, slows down gastric emptying, and actually stimulates insulin production. That's GLP-1. Remember that, GLP-1, glucagon-like peptide 1. That's what these. Remember, that's Ozempic, Trulicity, Bydureon, all those. That's what they are. They're GLP-1 only drugs, and they lower glucagon, and they actually lower glucagon. Why would that be important? Well, because glucagon stimulates hepatic glucose output, which raises glucose, and you want it to be suppressed in people with diabetes, especially after they eat. So GLP-1, we know a lot about GLP-1. What about GIP? Well, GIP probably does also have some central appetite effect, and also may reduce body weight in and of itself. There's some data that says that GIP And remember, we're talking about tirzepatide. I'm just going to focus again. Tirzepatide, now called Mounjaro, actually has effects on both GIP and GLP-1. And the GIP part makes it very unique. Well, so again, GIP, my lower body weight, it does increase insulin. We know that very, very well. It may have some really good effect on insulin sensitivity in the adipose tissue and perhaps muscle too. That is interesting. Think about that. So now we have a drug that does all those things we talked about already, the GLP-1 effects, and we have a drug that magnifies insulin production and increases insulin sensitivity, and both in the fat and probably also both in the muscle as well. So of course, what is that going to do? Going to lower glucose, might help lower weight. Well, we're going to take a look at some of the data in a minute. Would you see more weight loss with this two dual effect drug, or not? And well, we're going to find out more about that. So that's kind of the tirzepatide Mounjaro, what it is, what it does, and what it should do at least. And we're going to talk about what it does here in a minute. All right, so let's talk about the data that got it approved for treating diabetes. Let's talk about the data that got tirzepatide. Mounjaro is the company name. Of course, talk about the data that got it approved. Well, I'm going to make short work of this, but I'll tell you there were 5 different trials that were done in people with diabetes. Of course, the approval right now is diabetes. Do we hope it's going to get an obesity approval? Well, I'm going to ask you about that. We're going to look at the data here in a minute. And so diabetes, these trials, every company comes up with a name for their trials, and in this case it's the SURPASS trials, SURPASS 1, 2, 3, 4, and 5. There's one called 6, 2, and I'm not going to say anything about it because it's not published, but the SURPASS 6 trial is the one that is going to look at cardiovascular outcomes. And you know that every drug has to have a cardiovascular outcomes trial. We don't have it yet. It's too early for tirzepatide or Mounjaro. So SURPASS 1 is give the medicine in addition to diet and compare it to placebo diet. SURPASS 2 is give the drug and then compare it to one of the really good GLP-1 meds, Ozempic. SURPASS 3 is compare it to Tresiba as initial, that's the basal insulin, that. The basal insulin is first injectable. So either people on orals get the tirzepatide Mounjaro, or they get Tresiba as initial injectable. And then there's a trial that compares it to Lantus as first injectable, or Glargine, And then there's a trial, and that's the SURPASS 5, that actually gives it in addition to insulin. So it's been studied in pretty much every scenario. And let me just tell you, make a long story short. Do we want to go through all 5 of those trials? Oh, we do, but we don't. It would take too much time. I'd love to. But actually, what happens here is you take people with A1Cs in the mid-8s, and in the SURPASS 2 trial, for example, these are people who are on metformin alone and diet, and they're given either Mounjaro 5, 10, or 15, and those are doses that we can use compared to Ozempic. Now, they didn't have the Ozempic 2 milligram, that's the new higher dose, but they had the 1 when they did the study. So you compare all those different doses added to the metformin, baseline A1C 8.3. What would you hope for if you add one medicine on top of metformin, and if the A1C is 8.3? Just you can answer to yourself what. I see a question. There's no evidence for teratogenicity. We don't have any data on PCO either, but we have data on diabetes, and that's about it right now. And so what happens if you add it? Well, it turns out that the A1C reductions were like 2, 2.2, 2.3 at the 3 different doses, 5, 10, 15. Think about that. Most of the time, most people tell me they'd be happy with a 1-point drop. We're getting to 2.3, and that's really pretty good. And in the group that was given Ozempic, the drop was also very good at 1.9. And so that is the bottom line there. And so the rest of the trials showed very similar results. So really, really good drops in the A1C. This is going to be a very interesting diabetes drug. We know that. But then if you go on and take a look at some of the other information, and I'll tell you right now, when we record this later, we're going to throw some of the slides in the background. I'm not going to be talking slides right now, but you'll see the data if you come back to it and replay it. I'm going to put some of this up there, but I'm giving this to you verbally right now, completely verbally. And so what about the weight? What do you think is going to happen there? Well, I mean, how many pounds would you be happy with? Well, it turns out that the weight loss was quite substantial. And if you look at percent body weight lost, we'd be happy with 5% body weight loss, right? From baseline, we'd be happy. That helps everything. But in one of the trials, we're going to go back to that SURPASS-2 when you add it to metformin, and people weighed about 200 pounds. They lost up to, the people that were on the 10 milligram dose lost about 9-point-something% of their body weight, 9-point-something%. And the people on the higher dose, the 15, lost 11.2%. And that was superior in that case to the comparator. And really, when you look across the board in those trials, people are losing up to 10, maybe more percent of their body weight. This is mean, and I don't mean like mean. I mean mean losses. And I'm gonna glance over. I have some information to the side here that we might be able to display when we put up the slides later. But actually, if you ask what percent of people on the 15 milligram lost greater than or equal to 15% of their body weight, 15%, think about that. Along with these improvements in the glucose, it was 36% lost that much. And another really interesting outcome, it was an income too, but in one of the studies was if you look at the percent of people that had an A1C less than or equal to 6.5, like really good, also had a weight loss of greater than or equal to 10%, fabulous, and no significant hypoglycemia. Guess what percent that would be if you had the percent of people on the 15 milligram that got all three of those outcomes. Well, it was 60%. 60% of people had the A1C, the weight loss that was over 10%, and then no significant hypoglycemia. This is going to be a fun drug to use, and it's going to be really great for our patients, and that's what it's all about. And one study showed that weight loss was sustained. The SURPASS-4, which compared to insulin glargine, showed that the weight loss persisted for up to 2 years. So we do have longer-term data. It's not like it goes down like a Nike swoosh and then back up. It stayed down. So that's really good. And it turns out that we can slice and dice this about 100 ways, but about 59% of people in the tirzepatide on the tirzepatide in the trials lost greater than or equal to 10% of their body weight. So I'm not going to go any further there. I'm going to talk a little bit about side effects a little bit later, but the diabetes data looks really strong. So in summary, for this first part of the talk, tirzepatide is this one molecule, new class of drug, has a dual GIP and GLP-1 like effect. We've defined that, and these activities are probably at least complementary. They may be synergistic, and when it comes to various outcomes, including weight, and so we saw really robust reductions in A1C. So now what I'm going to do, that's the diabetes, and that's the approval. We have approval for treating people with diabetes type 2, not PD, not type 1, type 2, with this agent. But what I'd like to do now is go ahead and talk about something that's not indicated for yet, and that is treatment of obesity. And so you may know, and you may have read, and I'll just show you if you didn't, just to prove it, in New England Journal in July of this year, just a few weeks ago, there was a publication that looked at tirzepatide. You probably can't see that very well, but I'm not really intending to see it here. I'll flatten it out a little bit. Tirzepatide treating people just for obesity, and not specifically for diabetes, but for obesity. And I'm going to talk a little bit about that. That data is out. It's available. There's no approval at this point. But where do we go with this agent? Well, I think we go that direction. Now, the trials, and again, we're going to put up slides later, and if you want to come back and review this, you'll get me, talking about what I'm talking about right now with slides in the background. We didn't do that this time. I didn't want to distract you on Saturday morning. It's a little much to take on a Saturday morning, and so the weight loss trials, the pure weight loss trials. Now we're get away from diabetes. We're going to talk about pure weight loss trials. We're SURMOUNT 1, 2, 3, and 4. And the Surmount 1 is the one that was just obesity management. There is a trial, though, that's going to be done in people with type 2 for just obesity management and also blood sugar control. And then there's some others that are on the way too. And so let's move on and talk about the Surmount 1. And that's the one that got published as well. So in Surmount 1, basically you take people who are overweight, and I'll tell you more about the criteria in a minute, and you put them on the 5, 10, or 15. Now you start at 2.5, remember, and you make your way up to 5, 7.5, 10, 12.5, and then 15. That's what you do. And you take it up very, very gradually. And so, and then this study goes on for a good well over a year, and then compared to placebo. Everybody got very, very thorough diet education and, lower your calorie education. To get in the study, you had to have a BMI over 30 or over 27 if a person had comorbidities, and those included dyslipidemia, hypertension. They could have prediabetes, and they could have obstructive sleep apnea, and they could have cardiovascular disease too. They couldn't get in if they're going to have a surgery for obesity or if they had type 1. And one thing I want to tell you, if the demographics, when you look at the article, this is a well sort of recruited trial, and the average age was about 47, number one, about 69% overall female, and that's true of most of the trials. As far as racial sort of mix, white was about 80%, black or African American about 14%, and then Asian, and there was Hispanic was about 26%. So this is actually a very fairly representative trial of the population, and the average weight at the time of entry was 104 kilos. And let's see what else we want to talk about. Prediabetes. Yeah, about 40% of people did have prediabetes, and we're going to get a look at what happens with them. And I'm going to go through that in kind of a macro, really. Blood pressures were actually in pretty good shape. The people were on medicine. And so let me just jump into results. So you organize this trial. You bring people in that are overweight. They don't have diabetes, but they have comorbidities. They can have prediabetes. And you put them on one of the 3 doses versus placebo. And again, the placebo people did get dietary counseling. They just weren't left to their own and say, hey, go out there. They got some encouragement. Well, what do you think was seen as far as weight loss goes and I'm going to talk percent weight loss of the original body weight, and I'm also going to talk about weight in pounds. So what do you think was seen over 72 weeks? So this was fundamentally a 72-week study. Well, actually, and I'm going to talk about on treatment. Some people did drop off. A low percentage of people did drop off. Some because of GI side effects, and that's going to be something we're going to have to keep an eye on with this drug and any drug. All right. So what do you think? Somebody can put a note up there. What percent body weight loss did you think you might see at 72 weeks at the highest dose? Somebody put a percent. Give me a guess. Okay, well, I'm going to jump on in and let you know. At the lowest dose, 16%. Placebo people lost 2.4%. You know, that placebo effect's not bad. Not bad. But the people on 5 milligrams, 16%, and the people on the highest dose, 22.5%. That's percent. That's not pounds. That's percent. Think about it. Percent. And what would you be happy with when you tell people, I want you to lose some weight? I'm ecstatic with 5%. 7%, 10%, I am just bowled over. 22.9% at 72 weeks. Now, how does that translate in terms of pounds? Well, you can tell me. Remember, the kilo thing was about 100 and something, low, 102, I think I said, kilos at baseline on mean. Well, the people at the highest dose lost on average about 50 pounds. The people in 10 lost about 40 something, and mid 30s for the 5. I mean, that's just something else. And that was and so the average weight reduction, depending on the dose, was 35 to 52 pounds. So it depends on the dose, and the highest dose people lost more. Now, what about percent of people reaching their target? About 90% plus people lost more than 5%. That's one thing. Okay, so that's good. And we've always been really happy with that. About half of the people that were in the weight loss part lost more than 20%. And we can cut this all different kinds of ways. About 1/3 of people got greater than 25% of their body weight loss, the original body weight. And so, we can slice and dice this in 5 different directions. And it turns out that you might ask, well, what percentage of people actually responded? People ask that question. I do too. And what percent of people actually responded? It was 97.7%. So very, very low percentage of people didn't respond or didn't lose weight. So that weight loss data is robust. So I'm going to shift gears here a little bit. And so we talked about the data. And please, take a look at that New England Journal article. I'm not sure if it's open, free online or not, but you can find out. And that is substantial. And I'm going to ask myself too, what does that mean? And let's put some perspective on that in a bit. But before we do, let's talk a little bit about, we've seen the weight loss. We're talking about the weight loss trial only. We're not talking, we're not talking about the diabetes side. We already talked about that. Go back and listen to that again. If you came on late, we talked about diabetes and the approval. We talked about that earlier. And if you came on late, I'm going to tell you also, we're going to put the slides up a little bit later. And you get to look at the blinds behind me, but not the slides right now. And we'll put them up later. But what about improvement in metabolic measures? Okay, so people lose weight. We know that confers great benefit. Well, let's talk about the metabolic changes. And I'm just going to go through this. Again, I'm verbalizing this. I'm not going to show you the pictures right now. But if you look at body fat mass loss, we're talking about mean. This is a subgroup of people, about 160 people, who actually had DEXA body composition. It wasn't everyone. And the people on treatment, there was about a 33.9% fat loss. And then what about hemoglobin A1C? Well, remember, they didn't have diabetes, but they could have prediabetes, and they had A1Cs. And A1C reductions were like 0.4 up to 0.5 from a low to the high dose. So reduction in A1C was seen. And this is, okay, what about glucose, fasting glucose? Well, duh. If you lose weight, you're going to see the fasting glucose drop, right? Well, it's important to see numbers. We want numbers, we want data, and we want science. Well, the numbers are the fasting glucose dropped and dropped substantially, 7 up to 10 points. And the baseline glucose in this group was 95. Remember, this is not a group of people with diabetes. So there was kind of a pretty close to an average decrease in fasting glucose of 10 milligrams per deciliter. And again, focus, this is not a group of people with diabetes. You're not going to see like a 30 or 40 point drop as you do see in the people with diabetes. These are people that have either normal glucose tolerance, 40%, as I mentioned earlier, have prediabetes. And again, we're talking about the SURMOUNT-1 trial that was published in the New England Journal, in case you came on late. Now, insulin levels dropped also. Like another duh. If you lose weight, the insulin levels fasting are going to drop. And they dropped down about 4 or 5 milliunits per liter. And that's good. So less insulin resistance. And the percent change there was about 47%. With tirzepatide, because remember, insulin levels don't necessarily have to be real high in people who don't have diabetes. What about change in lipids? Well, we see what we thought we would see. You lose weight, your triglycerides drop, and that definitely happened. 27% decrease in triglycerides. That's pretty good. That's on par. It may even be better than the drop we see with some of the medicines we use for triglycerides, depending on the baseline triglyceride too. And so the HDL went up about 7.9 points, and so free fatty acids dropped. What else do you want to know? LDL dropped about 6.9, and that kind of covers the territory. No surprise. Metabolic. This is a cardiometabolic drug, and change in liver enzymes, fatty liver, all that. Well, there was an improvement there too, and the decrease in liver enzymes information has to be explored further, because would this be a drug for fatty liver? We don't know. Do we think it could be? Oh yeah, we do. We do. This we does. But I mean, I'm not representing anyone but myself here. But you know, if you lose weight, fatty liver gets better. I think it's safe to say. Systolic blood pressure, there were reductions there of 4 or 5 points. Reductions also in diastolic, and so that's also no surprise. And remember, these weren't people with really high pressures to begin with. They're like 123 systolic, and diastolic was about 79. So if you drop 3 millimeters of mercury, systolic, diastolic, that's actually a pretty nice drop. So the summary of efficacy results would be that weight reduction leads to significant improvements in multiple metabolic parameters, as you would expect. And so that's actually a really big deal. A fairly high percentage of people actually converted from prediabetes to normal glucose tolerance too, and so that's also really, really interesting, I think. So is it going to be approved for prediabetes? I don't think so. But is it going to be approved for obesity? I frankly think, based on this trial, and hopefully there'll be another trial that says the same thing soon. And do I think it's going to get approved for obesity management? Yes, I do. Do I think it needs to hurry up? Yep. And so you know, let everybody know about that, the wonders. And the weight reduction was actually sustained over 72 weeks. We want to see longer term data, but you don't see any kind of inflection up out to 72 weeks at all here. And will it maintain without the drug? I don't think so. Are you going to need to continue taking the drug to keep the weight loss? I think so, don't you? But anyway, it's really interesting, the data that we have here. And all of the metabolic parameters got better. Let's then finally talk about side effects, and then we'll close, and I'll take a few questions. Well, the side effects, what are they going to be? They're going to be GI, nausea, vomiting, diarrhea, constipation, and there will be a dose-related effect there. The higher the dose, the greater the effect. Does that make people discontinue? Some people did. A low percentage of people discontinued because of GI side effects. But you know, just let your patients know. The nausea, the vomiting, most of those effects tend to be early on, and they tend to improve over time, but not always. And if you look at the data, the nausea was greatest in the first few weeks, and then it tended to reduce, even though the doses were going up. Remember, you start with 2.5 on the diabetes side, and it was done on the obesity side too. You start at 2.5, and then you move the dose up as you need to, and as is tolerated, and actually discontinuation rate because of GI side effects was, let me take a look here, what was it? 0.5 placebo, and it was 1.9% at 5 milligrams, 4.4 at 10, and then 4.1 at the 15. Other side effects, mainly GI, and that's going to be it. But what else? Well, hair loss, dizziness, injection site reaction. When people lose weight, they get hair loss. It always gets better. Dizziness could be caused by blood pressure drops and orthostatic. You know, you may have to reduce the blood pressure meds when people lose weight, as you well know. So let me finish. You've been very patient. You've hung in there for a bit of time here this morning on Saturday morning. And so let me just give some perspective briefly. I've kind of given it throughout, and you have your own perspective, I know already. And I think, first of all, tirzepatide, Mounjaro is what it's called for diabetes, is an effective addition to our diabetes treatment armamentarium. And we've sent quite a few prescriptions out and related to diabetes, and it has a really good weight effect in people with diabetes. You know, that percent, 10%, 15%, some people achieve that with this drug. You've got to watch out for the GI side effects for sure. It has that notable effect on weight loss in people who don't have diabetes. And now, when I look at the data, what in my mind, what does it look like when I see that kind of weight loss? And when you look at it, what does it look like? I mean, and I don't want to overstate this because I just want to, you know, be as factual as possible. But you know, it kind of looks a little bit like bariatric surgery, and so we're just going to have to find out where we go here. And We know that it reduces cardiometabolic risk. We are waiting for the cardiovascular outcomes trial, and I'm not going to guess what it's going to show, but I'm hopeful. And we speaking of hope, we're hoping for an approval for weight loss as soon as possible too, and we know that cost is going to be a factor, always, and that's not going to change. And I think that once it gets approved for weight loss, the costs will be improved because it'll get covered. We know that. Now we're getting some coverage with diabetes too. We're getting our feet wet with that. So thank you very much for your time, and thanks for watching this presentation on cardiovisual. And please look at the cardiovisual app for other updates. And I'm of course Tom Blevins again, just to kind of close, talking about tirzepatide, the new agent, which is called Mounjaro for diabetes. And we talked about the tirzepatide data that came out in New England Journal a few weeks ago, and we talked about the SURMOUNT-1 trial, and really fascinating information in the weight loss area. And there, let me just show this. There's see all those bars down and all that information. It's all there, and we're going to put this up on slides too later. And so come back if you want to look at them. And please take a look at other topics on the cardiovisual app that I participated in, and many other people too. So thank you. I'll close and I'll open for questions. And let me see what questions we have. Zach is putting together a list of a few questions that have come across. One question I got, and I just want to be really clear, because I know that some of you came at different times on the presentation, and somebody asked me if it's approved for weight loss, and the answer is no. Is it approved for treating prediabetes? And the answer is no. And will it be? I don't know. But if most people who have prediabetes are going to be overweight, and if you get an obesity indication, then likely there'll be coverage for many people. So we're waiting for that. And that's one question I got. Another question I got is there any information on polycystic ovarian condition? And the answer is, it's a great question, because those people are overweight typically, not always, but typically overweight, and also insulin resistant. And we know that weight loss can help them reduce their insulin resistance. We think that the insulin resistance has something to do with the disease itself. And the high insulin levels might stimulate the ovaries to overproduce testosterone and all that. And so weight loss is sort of a very important part of treating PCO. Do we have an effective way to get people to lose weight with PCO? Some people do with the weight programs, and some people do with some of the other meds, but it's just challenging. Would I use this preparing someone for pregnancy, for example, as PCO? If we get an indication with the obesity, I'd be very careful. I think you could use it for up until a few weeks before. I don't think I want a person on the agent when they're working on pregnancy. During pregnancy, we don't know. There's no study looking at that, and I don't think there will be. I can tell you that in animal studies, the medicine might have some negative effects on the fetus on animal studies, so I wouldn't use it during pregnancy. And so anyway, back to PCO. Interesting question. We'd love to have a good, effective treatment for PCO, wouldn't we? Or a good way to get people to lose weight who have PCO. So we'll see. I suspect there'll be some subgroup data, or some like a investigator-initiated trial. Maybe we should do that here. I don't know. Thank you for that question. Let's see. Any other questions regarding tirzepatide? I think I see a couple more coming in. And one question is, what is the GIP receptor? What is it? Well, what is it? That was let's see if I can get you back. That was an upsetting question, I guess. I don't know. But okay, so the GIP receptor is a receptor that is definitely on beta cells, and it also is throughout the body. So the GIP receptor, this is an important receptor. It may be in the brain too. It looks like it is. And again, this receptor is clearly important when it comes to insulin production, because when we have an agonist, something that stimulates it, like the Mounjaro tirzepatide, the drug we're talking about, then you get more insulin production from the beta cell. It looks like there's probably some GIP receptors in fat cells and also in muscle cells too that help increase insulin sensitivity. I mean, for a long time, all we talked about is insulin resistance when it came to managing diabetes, and then we got this new group of drugs called GLP-1s, and we started talking about other things, and now we're kind of going back around. I used to call, just to kind of characterize, I used to call GLP-1 meds the Renaissance meds in treating diabetes, because they did all those things. GLP-1. This has to be called in Renaissance Plus, I think, or something like that. So that's my best answer there. Keep an eye out for GIP. GIP, we're going to talk a lot more about it. Is the drug teratogenic? I think I sort of answered that earlier. Not that we know of. It's been studied in preclinical studies. No evidence for teratogenicity. And what are some of the side effects? We talked about that too. Really, your main side effects, and some people are not going to be able to take it. Let's face it. That's true. A lot of medicines we have, great meds, but if you can't tolerate them, you just can't tolerate them. GI, nausea, vomiting, diarrhea, constipation. I mean, it's funny when you tell people, oh, you can have diarrhea or constipation. What? But, and also, interestingly, decreased appetite is considered an adverse event too. But now, gallbladder disease might be more common in some of the studies with diabetes side, yes. And that's something to know of. Anytime people lose weight, they have a higher risk of having gallbladder problems, And so if people get really a lot of nausea, vomiting, they might get volume depleted, so be aware of that too. Watch their creatinine, especially if they have impaired renal function. That's something you want to watch. And so be careful, and have your patients are going to like this med, I think, in the diabetes side, and it's going to be real interesting to see what happens on the obesity side. I think those are the primary questions that we've gotten so far. I appreciate your attention and your time, and I think we'll go ahead and close. And thank you very much. Again, Tom Blevins speaking on the Cardiovisual app. And we're going to have more information for you and more talks as time passes. And look backwards on that app, please do. And you'll see quite a few talks that we've already generated with me and many other people in the diabetes area, the cardiometabolic area. Thank you very much. All right, we'll close. Hi, I'm Tom Blevins at Texas Diabetes and Endocrinology, and I'd like to tell you a little bit about a medicine that's relatively new that we use to treat people with type 2 diabetes. Now, this is a pill. It's called the SGLT2 inhibitor class, and that's sodium glucose cotransporter 2 medicine. Let me tell you how it works. This is a medicine that actually causes the kidneys to release sugar. The kidneys typically, they filter the blood, and when they filter the blood, sugar in the blood goes into the kidney. Well, normally that sugar gets pumped back into the blood. And if you have a high blood sugar, that's not such a good thing. So this medicine actually inhibits that pumping back into the blood, and it causes the sugar to go out in the urine. And so this is essentially a medicine that makes the sugar go out in the urine. That's the way it works. We have a number of medicines that fit into this category. One is called Invokana, Farxiga, Jardiance, and then there's a new one called Steglatro. And there will probably be more of these. What do they do? How do they work? I mean, why do we use them? Well, clearly, if the sugar is pushed out into the urine, the blood sugar is lowered, and that's what we're trying to do in people with diabetes. It also can lower the blood pressure because it causes some fluid loss, and ultimately, because it pushes sugar in the urine, it can cause calorie loss, which can lead to weight loss. These medicines have gotten some really interesting science behind them, and there's some really big studies now that show very clearly that these medicines can actually lower cardiovascular, heart disease, other vascular risk. One of the drugs actually has been shown to reduce the risk of cardiovascular death in people who have known cardiovascular disease. And we're talking about heart disease and blood vessel disease and things like that. Some of the other ones have been shown to also reduce what are called major cardiovascular events, and that would be things like non-fatal MI, that is heart attack, non-fatal stroke, and then cardiovascular death. There's some interesting information that's developed that shows that these medicines may reduce the risk of heart failure in people with diabetes. And I'll tell you, people with type 2 diabetes have a higher risk of heart failure than the population who don't have diabetes. Also, there's some data that shows that these medicines may protect the kidney. So this is a really interesting drug class, and we've used these medicines a great deal. Every medicine has a side effect. These medicines can increase the risk of yeast infections in males and females. They can cause the blood pressure to drop too much, potentially, which would cause dizziness in people, and we have to watch out for that. They could cause a little bit of dehydration, which could make the kidney function worse at first. But as I mentioned, most of the data shows that they protect the kidneys. And then one has actually a warning regarding amputation of lower extremity and toes and things like that. And so we have to be very cautious when using the medicines, but they can be very effective. I hope this information helps you understand the way these medicines work, their potential, their benefits, some of the science behind them, and also help you understand the risk of the medicine. Hi, I'm Tom Blevins at Texas Diabetes and Endocrinology, and I'd like to tell you a little bit about a medicine that's relatively new that we use to treat people with type 2 diabetes. Now, this is a pill. It's called the SGLT2 inhibitor class, and that's sodium glucose cotransporter 2 medicine. Let me tell you how it works. This is a medicine that actually causes the kidneys to release sugar. The kidneys typically, they filter the blood, and when they filter the blood, sugar in the blood goes into the kidney. Well, normally that sugar gets pumped back into the blood. And if you have a high blood sugar, that's not such a good thing. So this medicine actually inhibits that pumping back into the blood, and it causes the sugar to go out in the urine. And so this is essentially a medicine that makes the sugar go out in the urine. That's the way it works. We have a number of medicines that fit into this category. One is called Invokana, Farxiga, Jardiance, and then there's a new one called Steglatro. And there will probably be more of these. What do they do? How do they work? I mean, why do we use them? Well, clearly, if the sugar is pushed out into the urine, the blood sugar is lowered, and that's what we're trying to do in people with diabetes. It also can lower the blood pressure because it causes some fluid loss, and ultimately, because it pushes sugar in the urine, it can cause calorie loss, which can lead to weight loss. These medicines have gotten some really interesting science behind them, and there's some really big studies now that show very clearly that these medicines can actually lower cardiovascular, heart disease, other vascular risk. One of the drugs actually has been shown to reduce the risk of cardiovascular death in people who have known cardiovascular disease. And we're talking about heart disease and blood vessel disease and things like that. Some of the other ones have been shown to also reduce what are called major cardiovascular events, and that would be things like non-fatal MI, that is heart attack, non-fatal stroke, and then cardiovascular death. There's some interesting information that's developed that shows that these medicines may reduce the risk of heart failure in people with diabetes. And I'll tell you, people with type 2 diabetes have a higher risk of heart failure than the population who don't have diabetes. Also, there's some data that shows that these medicines may protect the kidney. So this is a really interesting drug class, and we've used these medicines a great deal. Every medicine has a side effect. These medicines can increase the risk of yeast infections in males and females. They can cause the blood pressure to drop too much, potentially, which would cause dizziness in people, and we have to watch out for that. They could cause a little bit of dehydration, which could make the kidney function worse at first. But as I mentioned, most of the data shows that they protect the kidneys. And then one has actually a warning regarding amputation of lower extremity and toes and things like that. And so we have to be very cautious when using the medicines, but they can be very effective. I hope this information helps you understand the way these medicines work, their potential, their benefits, some of the science behind them, and also help you understand the risk of the medicine. Welcome to Cardiovisual. My name is Tom Blevins with Texas Diabetes and Endocrinology in Austin, Texas. Today, we'll be talking about SGLT2s and the increasing need for endocrinologists and cardiologists to work together in managing our patients with diabetes.
Just as you mentioned, there's a lot of new exciting data in heart failure. As you mentioned, Farxiga, which of course is dapagliflozin. And dapagliflozin recently had an update to its indications. The current indications are reducing risk of hospitalization for heart failure in adults with type 2 diabetes and established cardiovascular disease, or multiple cardiovascular risk factors, and to reduce the risk of cardiovascular death and hospitalization for heart failure in adults with heart failure with reduced ejection fraction. Something we sometimes don't necessarily talk a lot with our patients about is the risk of heart failure in patients with type 2 diabetes. And there's a significantly increased risk of events in patients with diabetes relative to patients without diabetes. In fact, sometimes I'll ask my patients, I'll say, what is the most common complication of diabetes? And you really start seeing signs of hemodynamic change that we attribute to heart failure pretty early on in our patients with diabetes. So any improvement you can achieve in hemodynamics, in additional factors, really looks like gives us significant improvement there. So the most recent trial with Farxiga was DAPA-HF. And this was a trial that was designed to evaluate the efficacy and safety of dapagliflozin on top of standard of care in patients with heart failure and a reduced ejection fraction. Interestingly, this study had patients both with diabetes and without diabetes. After a 2-week enrollment period, patients were randomized to dapagliflozin at 10 milligrams a day plus standard of care. This was about 2,400 patients versus placebo plus standard of care, again, about 2,400 patients. Only 42% of these patients had diabetes. And after a median follow-up of about 18.2 months, dapagliflozin demonstrated a significant 26% relative risk reduction for the composite endpoint of worsening of heart failure or cardiovascular death. And in patients with or without type 2 diabetes at baseline, when you look at subgroup analyses, both groups benefited. And beyond that, your primary composite outcome and individual components, including hospitalization or an urgent visit for heart failure, hospitalization for heart failure, an urgent heart failure visit, or cardiovascular death, all favored dapagliflozin as well. Another thing that I think will be important to point out here is a similar trial with empagliflozin is now suggesting that this could potentially be a class effect. I think we'll touch on that maybe later as well. And Steglatro, which is ertugliflozin, hasn't met these endpoints yet. But I think this is an evolving story, and it'll be interesting to see where sort of the studies and sort of the evolution of these indications go. And sort of building on that, I was going to get Bob's input on how cardiologists view these recent studies.
Probably the easiest way to look at it is take 35 trainees and ask them about the drug. And they know a little. They don't understand the mechanism. They're not endocrinologists, so they're not thinking basic science. But I think the impressive part is that these numbers are indisputable. Whatever drug you want to pick, we're now starting to see a benefit in heart failure. And it doesn't have to be type 2 diabetes. So now you have a cardiovascular drug here. And you can use it or not, but this one saves lives. And I don't have one as powerful as this. I mean, you can use sacubitril, but the side effects is higher. This class of drugs is extremely well tolerated. Sacubitril doesn't make you lose weight. You don't lose calories. You don't lower your blood pressure like this one does. I mean, when you take and give it to non-diabetes folks and they show a benefit, it's impressive. And two, it occurs very quickly. This doesn't take a long time to see a benefit like you saw with these other compounds. So I think the cardiology guys, one, don't understand the mechanism, which means that primary care and endocrine, who use it mostly, will have to spend some time with them. They were very slow uptakers on statins. Took a long time for them to start using statins. I think we're mostly into put a stent in the vessel and we go after ischemic heart disease because we're comfortable with that. That's what we trained on. Heart failure too is high blood pressure. This drug will lower your blood pressure around 4 or 5 points. So it's difficult to not know this drug. To me, this is actually a cardiovascular drug, but was marketed under the auspices of endocrinology with diabetes. But we didn't know that at the time. But so was enalapril. Enalapril was an insulin sensitizer. It came on the market actually to lower your blood pressure, but when you looked at the data, it lowered your actual glucose levels. So I think that anything good for endocrine is probably good for the heart, and this just shows you spectacular results. So I think certainly the heart failure is the big ticket item for the cardiologist. Cardiovascular events, I don't think so much for. We didn't decrease acute coronary syndrome here in any of our trials, but we did decrease cardiovascular death. I'm not sure the exact mechanism. We can talk about that. But the kidney is the other big player here. Those 3 big areas, and the kidneys to the cardiologist are pretty important because in the lab, we poison kidneys a lot of times with dye. And diabetes patients are number 1 on my list to watch for.
My name is Dr. Paul Tucker. I'm an interventional cardiologist with Texas Heart and Vascular in Austin, Texas. Today I wanted to talk to you about chest pain. As you might imagine, there are many causes of chest pain, many of which are not the heart. For patients going to the emergency room, it's actually been shown that only about 5.5% of those patients are actually having a cardiac event, which puts them at risk for a heart attack. In the United States, chest pain accounts for approximately 7.6 million annual visits to the emergency room. Fortunately, the vast majority of these patients are not actually having a heart attack. Multiple non-cardiac causes of chest pain exist. Basically, anything in your chest can cause chest pain. It can be your chest wall, it can be the esophagus, it can be your heart, it can be the aorta or blood vessels leading from the heart, it can be the pulmonary circulation, such as blood clots in the lungs, it can be the lung lining itself or the pleura, which frequently causes pain with breathing or taking a deep breath. It can also be problems related to the cervical spine, the thoracic spine, and even stress and anxiety can cause chest pain. When a patient comes in with chest pain, usually the first test that is done, whether it be the doctor's office or the hospital, is an EKG. The long word for this is electrocardiogram. This is a tracing of your heart's electrical activity, and it can usually tell if you are having a problem with your heart, such as a heart attack. Another test that we do is a set of cardiac enzymes. These are molecules that are released into your body from your heart when there's heart muscle damage. The most common cardiac enzyme checked is the troponin. If the troponin is going up, it usually is a sign that there is something going on with the heart. If a patient has an EKG that does not show a heart attack and their cardiac enzymes are negative, then the usual next step is to perform some sort of stress testing. A treadmill test is usually how it is done, with the patient walking on a treadmill. The usual protocol on a treadmill test is every 3 minutes, the belt goes faster and steeper until the satisfactory heart rate is reached. On the stress test, the patient's EKG is watched continuously, the blood pressure and heart rate are watched, and the patient's symptoms are observed. At the end of the stress test, the test is interpreted by a cardiologist who can usually determine if there's a problem or not. There are other types of stress tests. You can combine the stress EKG with nuclear imaging or with echocardiographic imaging, and you can also do what's called a chemical stress test. Another common test that is used to evaluate chest pain is an echocardiogram. The echo can reveal a lot of different conditions that can cause chest pain. A chest x-ray can be helpful, as can a CT scan of the heart. One of the tests that we use commonly in the evaluation of chest pain, especially in patients who are over 40 to 50 years old, is a calcium score. This is a test that looks at coronary artery calcification. It's a 5-minute CAT scan. It's usually done at the radiologist. It involves no needles and no contrast. And the number that is derived from that score can tell us a patient's risk. The score is usually somewhere between 0 and several thousand. The lower the number, the better. If the score is over 400, it does indicate that there's an increased risk of a cardiac event in the next 5 years. And for those patients, further testing is probably warranted. If a patient does not pass their stress test, or there are other signs based upon the EKG or the enzymes that they might be having a heart problem, the next test might be a coronary angiogram. This is a test where a doctor threads a little catheter, usually about 2 millimeters in diameter, through the wrist artery, called the radial artery, or through the femoral artery in the upper leg. The catheter is passed to the heart, and angiograms are taken by injecting contrast dye directly into the heart arteries to look for blockage. This is considered the gold standard test for diagnosing coronary artery disease. Patients frequently ask, if we find a blockage, what are we going to do? If the blockage is severe and it is felt to be causing the patient's symptoms, then frequently angioplasty or stenting is performed. Angioplasty refers to the passage of a small balloon to dilate up the artery, usually to make way for a stent. A coronary stent is a metal mesh that is usually shaped in the form of a cylinder. It is mounted on a balloon, and when it is passed into the artery and deployed, it actually pushes the plaque up against the walls of the artery, restoring completely normal blood flow to the heart. Another procedure most people are aware of is bypass surgery. This is a procedure where a surgeon takes an artery from your chest wall or a vein from your leg and literally creates a new blood vessel around the blocked artery. Basically, anybody having chest pain should get an evaluation, at least by their primary care physician. The physician can then refer you on to a cardiologist if necessary. On the other hand, if you're having severe chest pain, shortness of breath, sweating, nausea, you should go to the emergency room for that. You should never drive yourself to the emergency room with chest pain. You should call 911 and have the ambulance take you. The reason it is important to get evaluated quickly if you're having chest pain is that if you are actually having a heart attack, that means part of your heart muscle is dying. Every minute that goes by, more heart muscle cells are dying and will not come back. So time truly is muscle, and it's super important to get to the hospital right away. Chest pain that's coming from the heart frequently has some other characteristics. Frequently there is shortness of breath with the discomfort. It is described as a tightness or heaviness or a squeezing sensation rather than a sharp pain or a shooting pain. It tends to have a feeling of impending doom associated with it. There's frequently sweating involved, nausea, upset stomach, and sometimes the discomfort when it's from the heart radiates into the neck, jaws, or to either arm, but most commonly the left arm. It can also radiate through to the back. I've seen in my practice over the years multiple different ways that patients can present with heart attacks. Sometimes it's not chest pain, but simply shortness of breath or fatigue. Other times it can be pain in the back, pain in the elbows, pain even on the top of the head as the only symptom. Very unusual, but it has to be considered.
Hi, I'm Tom Blevins at Texas Diabetes and Endocrinology. I'd like to tell you a little bit about a study that was recently published, and it was published in June of 2019. And this is another study that looks at a diabetes medicine and asks the question, does this medicine improve risk of cardiovascular disease? This is called a REWIND study. It's a study that looked at dulaglutide. Now that's the drug we use in clinical practice already. It's a weekly injection of that drug called Trulicity. And it looked at dulaglutide and cardiovascular outcome. This is a large trial done at 371 sites in 24 countries. And it involved men and women at least 50 years of age or greater. They had to have type 2 diabetes. And they had to either have had a previous cardiovascular event like an MI, heart attack, or stroke or something like that, or they had to have multiple risk factors. Well, it turns out that only 31% or so had a history of a known cardiovascular event. That means that the other group, the majority of the patients actually had risk, but they didn't have a history of an event, so you would call them a primary prevention subgroup, and actually it was the majority of the patients. The way the study was done is they were given either the active agent, the dulaglutide, which is the weekly injection, or they were given placebo injection, and they were followed for over 5 years. What was being looked at here, the primary outcome measure, was first occurrence of either non-fatal MI, non-fatal stroke, or death from cardiovascular causes. That was the primary outcome measure. There were about 9,900 patients overall, and the mean age was 66 or so. The A1C at baseline was 7.2. It was already pretty good. And about 46% were women. And they were then put into the study, and they were divided into the two groups. And I have a slide that shows the baseline characteristics. If you'd like to refer, I'll tell you this was a well-randomized study. Ages, most of the factors you normally look at were well randomized into each group. Let's go right to outcomes. At 5.4 years or so, there was a reduction in the primary outcome measure that I mentioned earlier in favor of course, the dulaglutide. And so the data is here. Much of the reduction was in the area of non-fatal stroke, and a bit was in the area of cardiovascular death. But if you look at the composite, there was significantly fewer events in the people on treatment versus not. And I have a subgroup analysis I'll show you here. You can see that most groups showed favorability in terms of results with the dulaglutide. And then also there's some data here I'll show you that shows that hemoglobin A1C was a bit lower in the people on the active agent. The weight was lower, systolic blood pressure was lower, and also the heart rate was a bit higher in the people on the active agent. And that's some marker data that might be interesting. So really, what does this mean? Where do we go here? What are the clinical implications to us in practice? Well, that is that dulaglutide reduces major cardiovascular outcomes in people who are, you might consider to be middle-aged, and also older people, men and women, with type 2 diabetes. And it's a safe agent in the cardiovascular realm. It actually seems to reduce events. And this is the first, by the way, and this is important to know, major cardiovascular trial of a medicine used to treat people with diabetes to lower the blood sugar that had a large primary prevention treatment group. And that group did have benefit. This adds to a very growing bit of evidence that this type of medicine, the glucagon-like 1 peptide agonist, the GLP-1 receptor agonist, this shows that these agents reduce major adverse cardiovascular events, at least the ones that have been studied that show the results like the dulaglutide. Really interesting information, I think important to us in clinical practice. Go ahead and get started. Yeah, so I'm Tom Blevins. I'm at Texas Endocrinology. It's actually Texas Diabetes and Endocrinology in Austin, Texas, the middle part of Texas, and I am an endocrinologist. And thanks for tuning in to CardioVisual. And this is the app where you can listen to lots of information about cardiovascular and also metabolic conditions. And of course, I see a lot of people with diabetes and metabolic, and that's what I talk about a lot on CardioVisual. Now, we're going to talk about, we titled this The Skinny on GLP-1 meds, glucagon-like peptide 1 meds, and I also should have put in GLP-1 and GIP. I'll talk more about that in a minute. And so here, I'm in a single specialty clinic. We all do endocrinology, and we've done quite a number of the weight loss studies here. We have a clinical research department, and in addition, we have a weight management program. And of course, anyone who treats patients in any specialty these days is very interested in treating people with obesity. And you know, I'm not going to talk a lot about the complications. Hello, everyone. I'm not going to talk a lot about the complications of obesity. I think we all know but in general, obesity it has many negative effects on people, including metabolic conditions. Obesity is associated with diabetes, lipids problems there, cardiovascular disease, the whole 9 yards, insulin resistance, cancer, you can go down the list, orthopedic problems. And then we have patients who are not only obese, but also fit into the category of severe obesity with a very high morbidity and high mortality. And actually, there's really a sense of urgency to get them treated and get them turned around. The challenge that we've had over many years is that really we haven't historically had that many tools. We have all kinds of weight programs, commercial programs. We've had some medicines and that have been somewhat effective. With that as a backdrop, let's go ahead and talk about a history of GLP-1s very quickly. And you recall that medicines like Byetta have been out. Byetta was the first one. The exenatide was the first one that was brought forth back many years ago, 15 maybe years ago. And then came Victoza probably about 12, 13 years ago. And those were great. They were approved for diabetes treatment, and that's what they did, and they were really good. And people happened to lose some weight with them. And then along came Trulicity and then Ozempic. And I'll flip back and forth between the drug names. And, Victoza's liraglutide, Trulicity is dulaglutide, and then Ozempic, semaglutide. So the medicines we've had approved for diabetes are Trulicity, Ozempic, Rybelsus is the oral, and now more recently Mounjaro. And we're going to talk more detail. The one that has the weight loss approval, those are all approved for treating diabetes, and they lower the glucose and they lower weight too. And the one that we've had most recently approved for weight loss is Wegovy. Of course, Saxenda was approved too, but Wegovy is the one, it's semaglutide. And as you well know, all of you in the audience, and these are the names here in the US, Wegovy, Ozempic, and then the oral is Rybelsus. They're all semaglutide, all of them. They're all semaglutide, you all know that. They're all the same exact molecule. And so we've had all of these approved, Wegovy for weight, and then the most recent approval, of course, was Mounjaro for diabetes, and that's tirzepatide. Now, these are not for type 1 diabetes. They've never been approved for type 1. And in the diabetes realm, there's a boxed warning, and you know that it says that in male and female rodents that these agents increase the risk of thyroid C-cell tumors, which in humans would be medullary thyroid cancer. So there are these warnings and contraindications. The glucagon-like peptide 1 medicines work by slowing gastric emptying, and that makes people get full faster. They also have a direct effect on appetite, and they can reduce appetite. They also increase insulin production, and that's good for the people with diabetes. And of course, when people don't have diabetes and they get these meds, it doesn't cause hypoglycemia, really, when you give the meds by themselves, because that effect is glucose dependent. And these medicines can lower glucagon too, which reduces hepatic glucose output. So it's all very diabetes oriented, though we're going to start shifting more into weight loss. And Mounjaro is a combined GLP-1. It has GLP-1 like effect. It also has GIP effect. Now GIP is glucose dependent insulinotropic polypeptide. Can you imagine? Just say GIP. So Mounjaro has both. Mounjaro can increase insulin sensitivity. Well, it sounds like I'm giving a diabetes talk here, really, but I'm not. We're going to talk about it. These medicines can reduce appetite, and appetite is a demon, and it needs to be put back into its cave because it causes people to eat and gain weight. So reducing appetite is a big deal. And also, these medicines can slow gastric emptying, as I pointed out, and as you know, and that can make people get full faster and reduces intake. So a slow, in a way I could say a slow stomach is a good stomach because when you slow it down, it gets full faster and it stops eating. Historically, we've been really happy. We love the idea that people can lose 5% of their body weight or maybe 10%, and we're really happy about that. And so we struggle to get 5 or 10%. People lose, they gain, and there are all kinds of commercial weight programs and other things, as I mentioned, that we've used in the past. We've struggled and struggled. I think we're kind of entering a new era. I'm going to talk a little bit about these various agents, and I'm going to focus on their weight loss potential. Trulicity. Let's talk about Trulicity. That's dulaglutide. And dulaglutide. And just in brief, that medicine's been around for a while. It's injectable once a week, as you know, and it's a peptide hormone, GLP-1 sort of analog, and it can cause weight loss. And at the different doses, the doses now go up to 1.5 up to 4.5, the starting dose 0.75, but the highest dose, people can lose weight, like 10 pounds, and lower their A1C as well. That's great. It's exciting. And in a study that looked at people who had a particularly high BMI, a BMI of like 33 or so, the people that were on the Trulicity at the highest dose lost even more weight, like 12 pounds. And so that's really good. That's great. And then along, as I mentioned, along comes semaglutide. Remember, semaglutide is, in the U.S. is called Ozempic. Rybelsus is the oral, and then Wegovy is the one that's approved for weight loss, and it can be increased up to 2.4 milligrams per week, injectable. And then I'm going to talk a little bit about the Wegovy trials first. And Wegovy is approved for weight loss, and let's talk about what that means. And this kind of helps us progress on through this talk. Well, there were 3 studies that looked at the weight loss with Wegovy. Again, this is semaglutide, as you know. And study 1 was just people who had overweight and comorbidities. Study 2 was diabetes with obesity. And study 3 was overweight with comorbidities. And they started on an intensive weight program before they got on the med. And essentially the bottom line here is that the change from baseline in body weight was 14.9% in the first study, 9.6% in the diabetes study. We're talking 9%. 9.6% from baseline. So remember, we're talking about 5 or 10% is where we want people to be. Well, they're getting that, at least exceeding with Wegovy. And these studies are typically these studies are like 68-week studies. They're over a year. And then in the other study with the intensive diet, the 16% was the percent weight loss from baseline. And now that's huge. That is huge. And then percent of people losing greater than or equal to 10% of their body weight. Again, greater than or equal to 10% of their body weight. In the study 1 was 66% of people did. Study 2, the people with the diabetes, 44.5% did. And then in the other study, the intensive study, 73%. So we're now talking a very, more than 50% in 2 of those studies lost more than 10% of their body weight. What about 15%? And again, if you just tuned in, I'm talking about Wegovy, which is semaglutide. Well, the percent of people in the studies that lost more than 15%. This is huge. I mean, if it was 20% of those, I would be happy. But in the people with obesity and overweight with comorbidities, 47.9% lost more than 15% with Wegovy. And then 25% in the diabetes group, and in the intensive control group, the number was about 53% lost more than 10% of their body weight, original body weight. 53% lost more than 15%. That is huge. So now we've kind of entered in this zone of, well, now we have meds that can cause people really to lose some really, really good weight loss. Lose some good weight, I should say. Have a really good weight loss. Now, along with the weight loss comes the benefit. What's the benefit? Well, if they have diabetes, their diabetes gets better. I mean, I'm not going to give you necessarily numbers here because we don't have time for all that. But also, if you look at these various parameters, their waist circumference dropped, the systolic blood pressure dropped a little bit, the blood pressure diastolic as well dropped just a little bit. And then A1C, of course, dropped if people had diabetes. If they didn't have diabetes, it dropped a little bit, but not that much. Cholesterol, the things happen that you would expect. The LDL dropped a little bit. HDL was relatively flat in those studies, and then the triglycerides dropped. That's what you'd expect. So these cardiovascular risk markers improved, and all good. And people losing weight, they're happier. We don't have data about long-term data about whether their risk of things like other things that are morbidities of weight go down, like cancer. We don't know. But we do think that weight loss is going to put us in a good place. We also know, and there was a trial called the STEP 5 trial with Wegovy at 2.4, the high dose. We know that if people lose that weight initially, that weight loss continues. It's not like a Nike, like a check up and go back up. It stays down. So as long as they keep on the medicine, and there is a study called the STEP 5 study that went out for about 2 years, and the weight loss remained. And it turned out that if I can give you tons of numbers here, and they'll drive you literally crazy because, they're all cuts in different areas. But if you look at the percent of people that lost more than 5% of their body weight at the end of the 2-year study, it was more than 5%. It was 77%. And of course, the people on placebo lost some weight too because they were on a program, and they actually 34% of them lost more than 5%, but nothing like 77% losing more than 5% of their body weight over 2 years. So this is a study that was kind of a longer study that looked at people out to 2 years, and that was again with Wegovy. We're talking semaglutide, and so this is great. This is great for all of our patients. And the approval there is for remember, it's obesity, or obesity, just plain old obesity, BMI over 30, or BMI over 27 with comorbidities, and many of our patients have those. So that's the approval. And we'll talk later about the cost, but we're talking about the science here now. And now let me say a word about Rybelsus. Rybelsus is the oral semaglutide. And we don't have much time to talk about that, but it too led to weight loss. It's been studied primarily in people with diabetes, and on various other meds, and it too led to weight loss, like 8 to 10 pounds or so. Very beneficial. And again, it's semaglutide, and there are probably going to be some studies going down in the future that look at much higher dosing, and there may be some interesting results there. We don't know yet. Now, also Ozempic. Ozempic, of course, is semaglutide, the same molecule that Wegovy and Rybelsus have. And in the Ozempic studies also, there was good weight loss in people with diabetes. These are people with diabetes in these studies, and the weight loss was 12, 13 pounds, very, very significant percent of initial body weight, and very beneficial for people with diabetes. They lose weight, their A1C improves, and what more could you ask for in the world of diabetes? This is for type 2 diabetes, not approved for type 1. And then Ozempic got approved up to 2 milligrams not so long ago, and the 2 milligram dose also lowers the A1C a little bit more and lowers the weight a little bit more than the 1 milligram dose, and the weight loss was up to about, in some of the studies, up to about 14 to 15 pounds. So this is wonderful for people with diabetes. Now remember, the Wegovy was in people who did and didn't have diabetes, and actually really remarkable results there for people who have diabetes and who don't. So that's the semaglutide GLP-1 story. It's a really nice story, which will evolve. I think new doses are going to be looked at, and we'll talk more about the future in a minute. But now let's talk about the newest one, and that's, what's it called? Yes, it's Mounjaro. In the U.S., it's tirzepatide, Tirzepatide. Now, this drug is in a class that's separate from GLP-1 because it has both a GLP-1 and a GIP effect. Now, remember, if you just tuned in or something, GIP is glucose-dependent, insulinotropic polypeptide. Stick with GIP, trust me. GLP-1 and GIP effect. Now, where does that take you? Well, that takes you to the fact that, well, you have a GLP-1 effect, as we talked about, slowed gastric emptying, get full faster, therefore eat less. Also, it has an effect on appetite, and probably that both of those effects, GLP-1 and GIP, both have an effect on appetite, as it turns out. The tirzepatide or Mounjaro reduces glucagon levels. That's a GLP-1 effect. And lowers hepatic glucose output. That's great for diabetes, and also it increases first and second phase insulin production, a direct effect on the islet cell, the cell that makes the insulin, and also the Mounjaro people can claim, because of studies that show it, that this drug increases insulin sensitivity, and that's probably a GIP effect. So you get a combined effect there, and really interesting. This drug is, let me emphasize, this drug is only approved for, is not only, but it's huge, really. It's approved for treating diabetes type 2. And it doesn't have a weight loss indication at this point. But let's take a look at the weight loss that was seen in the diabetes studies, and then we're going to talk about the weight loss that was seen in the studies that looked at people who didn't have diabetes. Now, it's not approved for that, but we do have data, and I'll explain that in a minute. Well, there was one study that actually looked at Mounjaro's effect in people on metformin. Add Mounjaro or tirzepatide, the combined GLP-1 GIP drug to metformin. What happens? Well, with a baseline A1C, the A1Cs dropped remarkably down by about 2 to 2.3 points from the 5 to 10 to 15 milligram dose. And the doses that I'll be talking about are 5, 10, and 15. And the 15 is the highest dose. And 5 is the lowest therapeutic dose. It's not the starting dose, but it's the lowest therapeutic dose. So from an A1C of about 8.3, a drop at the highest dose of 2.3 added to metformin. That's marvelous. And then what about weight? Well, sit down and to get ready. The weight loss was 16.8 pounds at the 5 milligram. These are people who started the study between about 200 and about 210 pounds in the different groups. And you can do the calculation on the kilos if you use kilos. And so that was 16.8 pounds at the lowest dose. And then at the highest dose of 15, the weight loss was 24.7 pounds. I'm going to pause. 24.7 pounds. And the percent body weight loss there was 11.8. So, we once again, we struggled to get 5 to 10 in the past, but now we're talking about medicines that blow right through there. And we're getting 11.8 at the highest dose of Mounjaro in people with diabetes. And I'll just tell you, if you look throughout that whole study platform with Mounjaro, when it's added to diet alone, when it's added to metformin, as I talked about, when it's added to SGLT2s, when it's added to anything, you pretty much do see that those numbers, like 15 to 16 pounds weight loss at the low dose, and mid-20s, anywhere from 17 to mid-20s pounds weight loss at the highest dose. And now I'm gonna really, this will drive you crazy, but let's take a look at some cut points. We're going to look at weight reduction greater than 5% in that study that we talked about, the first one. Weight reduction greater than 10% of initial body weight, and then weight reduction greater than 15% of initial body weight. And these are people with diabetes on metformin. And okay, so weight reduction of greater than 5%, 80% of the people on the highest dose got weight reduction of greater than 5%, 80%. That's remarkable. That's at greater than 5%. Now, what about greater than or equal to 10% of initial body weight loss? Well, up to 57%. The low dose 5 milligram got 34%, greater than 10% weight loss, and also the highest dose then looked really good too, and 57% of people lost greater than 10% of their initial body weight. And then if you look at the higher bar, what percent of people lost greater than or equal to 15% of their initial body weight? Now again, I'm just going to repeat this because it's important. These are people on metformin. You're giving them the Mounjaro or tirzepatide on top of it, and their A1Cs are getting better, their glucoses are getting better, and they're losing weight. Well, it turns out that 36% at the highest dose lost greater than or equal to 15% of their initial body weight. Now that's fabulous. And we're seeing that in clinical practice too. Of course, the drug's approved for diabetes management. It's not approved for weight loss, but patients really love to hear that their diabetes is going to get better and they're going to lose some weight too. And then to kind of finalize this, and then we'll close and I'll take some questions. I'll tell you that just about 2 weeks, maybe 3 weeks ago, on the 27th of April, Eli Lilly announced the results of one of their trials, the SURMOUNT-2 trial, that was actually a weight loss trial, but it was this trial was done in people with diabetes and obesity, and that includes a lot of our patients around the world with type 2 diabetes. This is a problem everywhere. And people on the highest dose in that study, they had about 938 people. Now let's just say not far from 1,000 people who were in the study, and they put them on the various doses of the tirzepatide or Mounjaro. And the people on the highest dose had a 15.7% on average body weight loss, and that's a percent, and that's around, it turned out to be an average of about 34 pounds. And even those on the middle dose, the 10 milligram, had about 13%. On the 10 milligram dose, about 13.4% of initial body weight was lost, and that was about 29 pounds. So we're talking some good weight loss here, not only percent but pounds, and the people in the placebo group also lost a little bit of weight, 3.3% of their initial body weight, and you can cut this in so many different ways, and this is not published yet, but it's the top line results were announced. 4 out of 5 people had a body weight reduction of more than 5%, and 2 out of 5 in that study, kind of similar to what we just talked about, isn't it, had a body weight loss of more than 15% of initial body weight. That's crazy. And then we can talk on and on about that, but those are remarkable results in people with diabetes. And I'm going to tell you about another study as I close out here, and it's going to blow your mind as well. And adverse events in that study, typical GI. And some people can't take it. It's always important to note. And some people discontinue. Discontinuation rate at the low dose was about at the 10 milligram dose was 3.8%, and about 7% at the 15 milligram dose. Interestingly, 3.8% of people on placebo discontinued, probably because they knew they weren't on the active agent. People just go off studies because they want the active agent. So anyway, there are side effects to every medicine, and the GLP-1s have side effects, and I'll emphasize that just a bit more in a minute. But that is the weight loss study in people with type 2 diabetes, not published, but will be presented at the American Diabetes Association meeting in June. Now, let's then back up, and you probably remember that in July of last year, there was a study in the New England Journal that was published, and it was called the SURMOUNT-1 for what that's worth. And I'll just tell you, go take a look at this. It's free online. And New England Journal of Medicine, July 21st of 2022. And it showed that they looked at the 5, 10, and 15 also, and it showed that participants lost an average of about 52 pounds, more than 20% of their body weight on the highest dose. That's on the highest dose. And actually, if you look at the mean weight changes, 72 weeks. Now, this is not a short-term study. It's longer than a year at least. That's kind of good. People on the 5 milligram dose lost 15%, 19.5% at the 10 milligram dose, and 20.9% initial body weight loss at the 15 milligram dose. And that was 52 pounds. That's crazy. So that's the data I wanted to present. And there's one more bit of data too. But let's just kind of pause a little bit and say, these medicines are great. They do have side effects, GI. Some people can't take because they have nausea, vomiting. They have some people get very slow gastric emptying, and they just can't continue. It's almost like their bowels just kind of stop. That's not very common. Most people tolerate. And there is a discontinuation rate in people who can't tolerate, and you're going to need to be careful. If people get very, very active GI side effects, then you might have to discontinue the med yourself because they might get dehydrated. And so there are definitely side effects here. Not everyone can take the med. And, the other question is, what happens if people stop with the weight? We know that blood sugar goes up if they stop the medicine, if they're taking it for the diabetes indication, but what happens to the weight when they discontinue? Does it stay down and stick there? And the answer is no, it doesn't. And this raises a bit of an issue and dilemma. There was a study that was an extension of one of the Wegovy studies. It's called the Step 1 study extension. And remember, people were on the Wegovy in those studies we talked about earlier, the semaglutide, for 68 weeks. Well, what happens after that if it's discontinued? Well, What do you think happens when people discontinue the med? Well, you know, we all have our own ideas, we have our own experience, but we actually have a study. What happens? They regain. And over a year, if they took the medicine for 68 weeks on average, they lost about 16 to 17% of their original body weight. And if they discontinued the med after 68 weeks and were followed for a year, it turns out that people regained about 2/3 of their prior weight loss. And that's what happened. They regained. Not all of it over a year, but quite a bit of it. And what happens when you gain weight? Well, your blood pressure goes back up, your A1C goes back up, and so the things that you accomplished sort of start to go back. So this raises some really interesting questions. It's no surprise to any of us, and that is, how long do we continue these meds? We know that in general, if we keep the medicine going at least out to 2 years, we talked about that earlier, the weight loss continues. Now we know that when we discontinue the med, people in that study at least, with Wegovy, semaglutide, gained 2/3 of their initial body weight, their weight loss back. And that was, again, over a year. So that's a dilemma. It looks like we're going to have to continue, which is that a surprise to anyone here in this audience? That you have to continue the medicine once you accomplish the weight loss? Any surprise at all? I don't think so. You know, if I put a person on blood pressure med, do I stop the blood pressure med once their pressure gets normal? No. If I put a person on cholesterol med, when I get the cholesterol normalized or where I want it at target, no. And I don't think we're going to be able to stop the weight loss med, which raises lots of questions. It's a major dilemma. Oh, thunder. It's a big dilemma. We've got some thunder going on here in Austin. Well, that's a dilemma, and that's a topic of another discussion. I will point something out. A really nice bariatric surgery study, people had the gastric sleeve primarily, was published not long ago, and I'm not even going to go into detail. You know, these people had about a 22% body weight loss after about number of years had passed, which is great. But now we're seeing that same kind of weight loss with these meds that we just talked about, GLP-1s and the combined GLP-1 GIP. So the question is, how long do we go? So the questions that remain, these are wonderful meds. These are wonderful meds. And everybody wants to be on them, right? Yeah, they do. And no surprise. Why wouldn't they? And there's a supply problem, of course. And that's been a real issue, which I won't get into. But how long do you continue them? Obesity is a chronic disease. It just doesn't go away. And you can't just cure it with a year of a medicine that works. Cost is a huge issue, huge, around the world. It sure is in the U.S. And those of you listening from other countries, I'm sure it's an issue there too. It's a huge issue, very expensive. And where are we going to go with this? Availability is, the factories can't turn this stuff out fast enough, as it turns out. Supply chain issues. And then the other thing is that I'll say that it's not like the science is stopping. There are other meds in development that I would call next generation medicines that are similar to these. They may be versions of these, and they look really good too. So we're in the middle of the Renaissance time when it comes to weight loss meds that actually work, which is really great. It's going to be great. It's great for our patients, the people we take care of. It's really great. And so we've got a lot of questions to answer. And that's the conclusion of my talk. And I want you to, please keep tuned to Cardiovisual for further updates. We'll probably go ahead and talk more about this in future episodes. So I'm going to take a few questions at this point. Thanks for tuning in to Cardiovisual, the Cardiovisual app. And we've just covered the skinny on GLP-1s and GIP meds. So let me take a few questions here. Some that have come through that we've compiled, some that came through earlier that we compiled, and I'll just answer a few of them because we're right at time, I think. Is Mounjaro approved for weight loss? The answer is no, not at present. It's probably going to get a fast track with the US FDA. Around the world, I don't know. And are there other meds in the pipeline for weight loss? The answer is definitely yes. And this is a hot area of research. It seems like we've gotten pretty far, but there are other meds that look really interesting, I'll tell you. Oh, that's a funny one. What is someone asked, what is Ozempic face? Does anybody ever get that question, or you've seen that term? Ozempic face. To me, it's the face of success. I mean, I've seen it. People say, "Oh, people have Ozempic face." I guess they get some thinning when they lose weight or something. That's just a sign of success to me. Well, and then I guess one of the questions that came through earlier must be from an endocrinologist or diabetes person. Is Mounjaro or maybe Ozempic going to be approved for type 1 diabetes? The answer is not that I know of. Weight gain and overweight is not owned by type 2 diabetes people. People with type 2 diabetes. People with type 1 get overweight too, but these are not approved for type 1, and so that's not currently. Well, I think we'll stop there. Hey, thank you all very much for taking time to listen in on the Cardiovisual app, and we hope to have other subjects similar to this and other cardiometabolic subjects and topics available in the future for you. Thank you very much. We'll go ahead and close the Tom Blevins. I'm an endocrinologist in Austin, Texas, and I'm at a practice called Texas Diabetes and Endocrinology, I'll say here in Austin. We have 3 offices, if you know Austin, and North, Middle, South, Round Rock, and South Austin. And I'm a boarded endocrinologist. That's what I do, cardiometabolic, diabetes, all those things. First, I want to talk about how tirzepatide or Mounjaro works. Now, first of all, it's a single molecule. That's one thing that's really important. It's not some double hook molecule. It's not something that kind of two things stuck together. It's based on GIP. And I'm going to use some terms, I apologize, but I'm going to define them. And GIP is glucose dependent, insulinotropic, polypeptide. And so now you understand why you want to say GIP and not that. I mean, who would want to say that? And GLP-1 is glucagon-like peptide 1. And we've been using meds, that are GLP-1 meds for a while, like Ozempic, Trulicity. They're weeklies, and they're working for us very well, and we use them a lot for diabetes. And then that Ozempic is approved, it's semaglutide, and it's approved as that drug called Wegovy that's used for overweight, for obesity management. So new world here, and this adds yet another twist to the new world. So it is a new drug class because it has GIP and GLP-1 like effect in one molecule, and it's actually novel, and it's a peptide. And it's engineered, and it has. If you're interested in, if you like to talk about amino acids, this one has 39 amino acids, and has what's called a fatty diacid moiety. Don't remember that, and it has a half-life of about 5 days, and so it can be given once a week. That's pretty nice, and it's an injection. It's liquid. It doesn't have to be reconstituted, and it doesn't have to be adjusted to renal or hepatic impairment. It's not metabolized there. It's kind of nice too. You don't have to worry about that. Well, what is this about? Well, GIP receptors are on the beta cells, and they actually agonize insulin production. So let me talk about what these two different receptors do. This is one molecule. That's why I said that, 2 molecules, see if you're awake and see if you're paying attention there. It's one molecule. Well, what GLP-1 does, and we've known this for a while, it reduces appetite, increases satiety, slows down gastric emptying, and actually stimulates insulin production. That's GLP-1. Remember that, GLP-1, glucagon-like peptide 1. That's what these. Remember, that's Ozempic, Trulicity, Bydureon, all those. That's what they are. They're GLP-1 only drugs, and they lower glucagon, and they actually lower glucagon. Why would that be important? Well, because glucagon stimulates hepatic glucose output, which raises glucose, and you want it to be suppressed in people with diabetes, especially after they eat. So GLP-1, we know a lot about GLP-1. What about GIP? Well, GIP probably does also have some central appetite effect, and also may reduce body weight in and of itself. There's some data that says that GIP, and remember we're talking about tirzepatide, I'm just going to focus again, tirzepatide, now called Mounjaro, actually has effects on both GIP and GLP-1, and the GIP part makes it very unique. Let's talk about the data that got tirzepatide. Mounjaro is the company name. Of course, talk about the data that got it approved. Well, I'm going to make short work of this, but I'll tell you there were 5 different trials that were done in people with diabetes. Of course, the approval right now is diabetes. Do we hope it's going to get an obesity approval? Well, I'm going to ask you about that. We're going to look at the data here in a minute. And so diabetes, these trials, every company comes up with a name for their trials, and in this case it's the SURPASS trials, SURPASS 1, 2, 3, 4, and 5. There's one called 6, 2, and I'm not going to say anything about it because it's not published, but the SURPASS 6 trial is the one that is going to look at cardiovascular outcomes. And you know that every drug has to have a cardiovascular outcomes trial. We don't have it yet. It's too early for tirzepatide or Mounjaro. So SURPASS 1 is give the medicine in addition to diet and compare it to placebo diet. SURPASS 2 is give the drug and then compare it to one of the really good GLP-1 meds, Ozempic. SURPASS 3 is compare it to Tresiba as initial, that's the basal insulin, you know that. The basal insulin is first injectable. So either people on orals get the tirzepatide Mounjaro, or they get Tresiba as initial injectable. And then there's a trial that compares it to Lantus as first injectable, or Glargine, And then there's a trial, and that's the SURPASS 5, that actually gives it in addition to insulin. So it's been studied in pretty much every scenario. And let me just tell you, make a long story short. Do we want to go through all 5 of those trials? Oh, we do, but we don't. It would take too much time. I'd love to. But actually, what happens here is you take people with A1Cs in the mid-8s, and in the SURPASS 2 trial, for example, these are people who are on metformin alone and diet, and they're given either Mounjaro 5, 10, or 15, and those are doses that we can use compared to Ozempic. Now, they didn't have the Ozempic 2 milligram, that's the new higher dose, but they had the 1 when they did the study. So you compare all those different doses added to the metformin, baseline A1C 8.3. What would you hope for if you add one medicine on top of metformin, and if the A1C is 8.3? You can answer to yourself what. I see a question. There's no evidence for teratogenicity. We don't have any data on PCO either, but we have data on diabetes, and that's about it right now. And so what happens if you add it? Well, it turns out that the A1C reductions were like 2, 2.2, 2.3 at the 3 different doses, 5, 10, 15. Think about that. Most of the time, most people tell me they'd be happy with a 1-point drop. We're getting to 2.3, and that's really pretty good. And the group that was given Ozempic, the drop was also very good at 1.9. And so that is the bottom line there. And so the rest of the trials showed very similar results. So really, really good drops in the A1C. And so what about the weight? What do you think is going to happen there? Well, how many pounds would you be happy with? Well, it turns out that the weight loss was quite substantial. And if you look at percent body weight lost, we'd be happy with 5% body weight loss, right? From baseline, we'd be happy. That helps everything. But in one of the trials, we're going to go back to that SURPASS 2 when you add it to metformin, and people weighed about 200 pounds, and they lost up to, the people that were on the 10 milligram dose lost about 9-point-something% of their body weight, 9-point-something%. And the people on the higher dose, the 15, lost 11.2%. And that was superior in that case to the comparator. And really, when you look across the board in those trials, people are losing up to 10, maybe more percent of their body weight. This is mean, and I don't mean like mean. I mean mean losses. And I'm gonna glance over. I have some information to the side here that we might be able to display when we put up the slides later. But actually, if you ask what percent of people on the 15 milligram lost greater than or equal to 15% of their body weight, 15%. Think about that. Along with these improvements in the glucose, it was 36% lost that much. And another really interesting outcome. It was an income too. But in one of the studies was if you look at the percent of people that had an A1C less than or equal to 6.5, like really good, also had a weight loss of greater than or equal to 10%, fabulous, and no significant hypoglycemia. Guess what percent that would be if you had the percent of people on the 15 milligram that got all three of those outcomes. Well, it was 60%. 60% of people had the A1C, the weight loss that was over 10%, and then no significant hypoglycemia. This is going to be a fun drug to use, and it's going to be really great for our patients, and that's what it's all about. And one study showed that weight loss was sustained. The SURPASS-4, which compared to insulin glargine, showed that the weight loss persisted for up to 2 years. So we do have longer-term data. It's not like it goes down like a Nike swish and then back up. It stayed down. So that's really good. And it turns out that we can slice and dice this about 100 ways, but about 59% of people in the tirzepatide on the tirzepatide in the trials lost greater than or equal to 10% of their body weight. So in summary, for this first part of the talk, tirzepatide is this one molecule, new class of drug, has a dual GIP and GLP-1-like effect. We've defined that, and these activities are probably at least complementary. They may be synergistic, and when it comes to various outcomes, including weight. So we saw really robust reductions in A1C.